So first of all, thank you very much, Holly and Satya and all colleagues to invite me to this important conference. And I'd be happy to share with you the WHO experience on AMR data sharing and analysis for policymaking in the WHO European region where I am based, where I function as the regional advisor. Excuse me. So, but let me first start 10 years ago with the European Strategic Action Plan on Antibiotic Resistance, which was adopted by all 53 member states of the region, in a recognition that, especially at that time, AMR was largely neglected in a large part of the region. There was also no systematic AMR surveillance in a large part of the region. There was recognized that there was a need for intersectoral coordination. And of course, as with all infectious diseases, antimicrobial resistance can be spread through travel and trade. And it was also recognized that there was really a need for international standards and data sharing. Now, surveillance in Europe, both AMR and AMC, has a long history, but not throughout the region, as I just mentioned before. In terms of antimicrobial resistance, back in 2001, the University of Antwerp started a European network called European Surveillance of Antimicrobial Consumption, or ESAC. 10 years later, this network was handed over to the European Center for Disease Prevention and Control, and is what we now call today ESAC-Net. In that same year, the University of Antwerp and WHO Europe went together to form the WHO Antimicrobial Medicines Consumption Network. Now, these two networks are using similar methodologies, so you could put the data together and get more of a regional overview. At the same time, or similarly in the antimicrobial resistance, the Dutch Public Health Institute, RIVM, started the European Antimicrobial Resistance Surveillance System, or EARS, in 1998. In 2010, this network was also handed over to the European CDC, and which is what is now called EARSnet. Similarly, we also reached out to the Dutch Public Health Institute, and together with the European Society for Clinical Microbiology and Infectious Diseases, ASCMID, we created the CSER network. And CSER stands for Central Asian European Surveillance of Antimicrobial Resistance. So through these two networks, we could expand AMR surveillance beyond the EU throughout the WHO European region. Now, for those of you who are familiar with EARSnet, you may have seen these so-called traffic light maps before. And depending on which year you look at or which bug-drug combination, you see different colors, the green colors depicting low prevalency of that bug-drug combination, and the more red and to the dark red are the higher prevalences. But what you can see is that there has always been, or at least until the CSER network, all the countries in the eastern part of the region where we did not have any data from. So this is why we started CSER network in 2012. And just quickly about this picture, these are not pictures of prevalence, but more, these colors are more depicting the development of the CSER network, where the yellow countries were countries that were part of EARS before it became EARSnet, but as non-EU countries, they could not be part of the EARSnet anymore. And of course, we picked them up in the CSER network. The orange country, Belarus, here in 2012, was the first country that we started visiting and started building capacity. And the blue countries were all the countries that were the target countries for our very new network in 2012. And you see throughout the years, we visited more and more countries. And in 2014, Belarus was the first non-EARS country to provide data to the CSER network, which we saw as a good victory. Then throughout the years, more and more countries both joined and provided data. And this is where we are today with 12 out of 19 countries providing data on an annual basis, and the others we are working very hard on having them generate and share that data. Now, we've done this through a number of implementation activities, of course, a lot of capacity building, both in the laboratory, wet and dry lab, but also on the data side with data management, recording, and analysis. We developed and used many protocols and templates. We, together with ASCMID and the UCAST Commission, we made instruction videos. We had a large number of consultants and experts helping us out, as well as other partners from WHO collaborating centers, for example. We did a number of projects to demonstrate to countries what was possible in their country, and we had a lot of surveillance network activities. We have both an annual meeting where the whole network is represented, and we also support national network meetings to build and strengthen national surveillance networks. And through that, we could publish annual reports since 2015. Since 2016, we've been combining also IRSNet data, so we are slowly building the regional picture. And as you can see here, there's a lot of information on these slides. I will not go into detail, but some of them are related to the way we are set up, and I'm happy to discuss afterwards. So, but of course, this has not been easy. And you can say we've been working for this on 9 years now, and there's still a number of countries that are not able to share data or quality data at an international level. One of the issues that we see is that are around sampling. Blood sampling is done quite infrequently in many of the countries that we work with. And if it's done, it's usually after repeated treatment failure. So we only get to see the worst of the worst situation. There is quite a limited capacity to perform antimicrobial susceptibility testing. And in general, there is not a very high regard among clinicians for microbiologists. There are a lot of data issues as well. Most of the data is still recorded on paper, and many labs do not have a laboratory information system. There's also data quality issues, of course. If you don't see many samples, if you don't analyze many samples, there's a lack of experience and expertise, of course. And also because there is a very low demand for these laboratory materials, it's a very, very difficult market to get into. And many large producers will not enter a market in the absence of that demand. So there's a few lessons learned here. First of all, that antimicrobial resistance surveillance based on bloodstream infections is quite challenging in low and middle income countries. And of course, if you do not take any samples, you will not have any data. If you don't have data, there will be no surveillance. There's a limited laboratory capacity, which is actually preventing doctors from ordering samples, because in their experience, a sample would take 7 days or more to return, and they may not even trust the sample due to quality issues. And as I mentioned before, there's a limited demand from the laboratory side, which is really hampering access to reasonably priced materials. Some of the lessons we've learned related to this is that this is something that we want to try, that AMR surveillance on urinary tract infections is much easier. It's also cheaper, it's about half the price, and over time it can provide the similar trends. So there's a very good correlation between bloodstream infections and urinary tract infections from a surveillance standpoint. If you want to start up surveillance, the first thing you need to do, of course, is to start with increasing the sample flow. Lots of initiatives may be very tempted to go in the more advanced methodologies, etc., but without the basis, without the fundament of actually taking samples, all those efforts will lead to nothing. Lab capacity building is really crucial, not only to improve the quality of the work, but also to improve the turnaround time. Because again, clinicians will not wait a whole week for a result, because it will not help the patient and it will not help the treatment decision. And it's also important to create the demand for laboratory consumables by stimulating routine sampling. This is what we've been trying to do in the so-called proof of principle projects that we've had now so far done in 4 countries. I have no time to go into details, but I will provide a link later in my presentation if you want more information. But the objectives of these studies, which basically are demonstration studies, is to stimulate routine sampling of patients, to improve quality of diagnostic support, including turnaround time, and to lay the foundation for antimicrobial resistance surveillance. Now, we also know that the quality of surveillance data may vary from institution to institution or from country to country, excuse me, which has a lot to do, of course, with the type of surveillance, the coverage, the sample procedures, and the actual analysis, both in the lab, but also the data analysis later. But we also know that data can only improve if it's being used. So there's no need to wait until data is perfect. So what we've learned here is that it's very important to indicate the quality of the surveillance data in your publications, not only to guide the reader and to make sure that the reader interprets with appropriate caution, but also for policymakers to base decisions on. And it may actually be a good advocacy to say, well, if you need more precise numbers or precise data, you need to invest. So we believe that data should be published with the appropriate disclaimer. And what is important, then the shortfalls actually become focus areas for further capacity building. This is what we've been doing in CSER. Excuse me? Oh. This is what we've been doing in CSER, where we have very distinct levels of evidence. Well, level A is the highest quality, where both the data is representative and of high quality. Level B may not be representative, but reliable data itself. Level C is neither. But this, we found, is a way to start improving the data. Now, in our CSER reports, we have these tables where on the left-hand side, you see the criteria for the classification, and on top you have the countries, and you have the actual scoring. Now, this scoring can then be used, again, to focus your capacity building or your network strengthening. And we've seen this working in two countries quite recently, Bosnia and Herzegovina and Serbia, really used this insight to improve their surveillance system, and they went from level B to level A. We also know that countries have different levels of antimicrobial resistance surveillance capacity. And of course, a lot of this has to do with priorities of the country in terms of what resources are made available, either financial, human, or technical. Now, this also means that we cannot have a one-size-fits-all. The support, the capacity building efforts should be both tiered and tailored. And of course, to increase the priority within the country, there's a lot of awareness and policy dialogue that can take place. But it's also, you have to have a good understanding of where the country is, and you have to start with the foundation. So first things first. This is also why in CSER we've had these different phases of country support. Phase one is where there really is a very limited basis for surveillance. This is where we do these proof of principle projects to start generating samples and data and do very basic capacity building and look at quality assessment. The next phase is where there is no surveillance, but there is at least some foundation or some basis to build on. This is where we really start focusing on the reference laboratory and help them set up their national surveillance network. The final phase is where there is a surveillance system in place, but we really need to strengthen the surveillance and we encourage participation in the global AMR surveillance system GLASS. So we're making progress. There are more and more countries in our region that are able to collect and share AMR surveillance data. There's more integration between the two major surveillance systems, both at ECDC and at WHO Europe. We are part of each other's coordination groups. We have joint antimicrobial resistance meetings. And this year we'll have our first full joint report with IRSNet and CSER. These tailored proof of principle projects are useful to initiate and improve national AMR surveillance. And we can also see that more and more countries are joining the global AMR surveillance system GLASS to complete the global picture. So I'd just like to briefly acknowledge my colleagues at the country office who are very, very valuable in setting things up for us, the WHO collaborating centers, the European Society for Clinical Microbiology and Infectious Diseases, and all the experts and consultants that have helped us. And I left in some slides for some further reading afterwards. And with that, I'd like to thank you for your attention.